Welcome back to Decode Healthcare with Harshal for part 48 of our 100-part ICD-10-CM guidelines series. Now, if you recall, in part 47, we locked down that tricky 28-day acute myocardial infarction rule. Well, today our mission is to master section IC9D of the CMS official guidelines. We're focusing entirely on cerebrovascular accidents, what we commonly just call CVAs, or strokes. We're going to lock down the critical and honestly sometimes really confusing distinctions between an active acute stroke, late effects coded with category I69, personal history captured with code Z86.73, and the incredibly strict rules surrounding TIs. This is absolutely foundational knowledge you need for ensuring your claims are accurate and completely audit-proof.
Okay, let's dive into this. Here is our roadmap for the session. First up, the CVA coding mission. Then, acute, sequelae, or history. Third, we're mastering category I69. Fourth, dual stroke scenarios. Fifth, TIA versus completed stroke. And finally, escaping Chapter 9 traps.
Section 1. The CVA Coding Mission.
So as medical coders, you really have to think like detectives. The medical record is your evidence, but the CMS ICD-10-CM official guidelines, those are your strict laws. They completely override any textbook you've got. We're sometimes lovingly called the fraud squad because our job is to accurately capture the exact story without ever maximizing beyond what's documented. We rely entirely on this text to build a flawless foundation. Look at the guideline right here. Category I69 is used to indicate conditions classifiable to categories I60 through I67 as the causes of sequelae. We are not guessing here, folks. Our coding logic has to be absolutely unassailable.
Section 2. Acute, sequelae, or history.
And this brilliantly illustrates our diagnostic decision tree. When a patient presents with a stroke-related encounter, the timeline literally dictates your coding path in a strict three-way split. You absolutely cannot mix these up. Step 1. Active infarction. If the stroke or hemorrhage is actively occurring and being treated right now, boom, you are in categories I60 through I63. Step 2. Past stroke with lingering deficits. So if the acute phase is over, but there are residual neurological issues, we jump to category I69. Step 3, completely resolved stroke with zero deficits. No deficits equals a personal history code, Z86.73. Remember, history codes basically shout that the patient no longer has the condition. Lingering deficits? Category I69. Zero deficits? History code. It's that simple.
Let's define that key term a little bit further, because it's a big one. Sequela. According to our guidelines, a sequela is a residual effect, a condition produced after the acute phase of an illness or injury has terminated. In the context of a stroke, think of lingering paralysis like hemiplegia, or swallowing issues like dysphagia, or even speech issues like aphasia. Now, what is absolutely vital to remember here, and man, auditors absolutely love to check this, is that there is no time limit on a sequela. None. The residual effect might pop up early on, or it could happen months or literally years later. Your code choice is entirely dependent on whether those neurological deficits persist today.
Section 3. Mastering Category I69 Codes.
Now that we know exactly when to use them, let's actually build them. Category I69 isn't just some basic list of symptoms. It functions as a highly specific combination code that tells the complete clinical story in one shot. It incorporates both the type of past stroke and the specific residual deficit into a single slot. For example, a past cerebral infarction that resulted in hemiplegia on the right dominant side gives us the single code I69.351. Or, let's say, a past non-traumatic hemorrhage causing lingering aphasia gives us I69.220. You aren't just broadly coding weakness or speech problems, no way. You're capturing the exact historical cause and the precise current deficit linked together perfectly.
Section 4. Dual Stroke Scenarios.
Let's move to and see how this builds, because this is where things get super complicated, and it's where a lot of coders get tripped up during audits. Imagine this timeline. Back in 2022, the patient had a stroke that left them with left-sided hemiparesis. Ongoing to today, they still have that residual weakness. But present day, they suffer a brand new acute ischemic stroke. Guess what? Both the I63 acute codes and the I69 sequela codes must be reported on the exact same claim. The old deficits don't just magically vanish because a new stroke happened, right? The care team needs to know the full complexity of the patient's neurological state.
And just to anchor this directly in the official CMS guideline text so you know I'm not making this up, let's look at the exact wording. It says, codes from category I-69 may be assigned on a healthcare record with codes from I-60 to I-67 if the patient has a current cerebrovascular disease and deficits from an old cerebrovascular disease. The guidelines explicitly permit, and frankly they expect, you to code both to capture that full clinical picture.
So, on an actual claim form, here is your layout. Slot number 1 is your principal diagnosis. That's I-63.9 for the new acute ischemic stroke because, obviously, that is the active, critical issue driving the current encounter. Slot number 2 is your secondary code, I-69.352, for the hemiplegia following a cerebral infarction affecting the left non-dominant side. That perfectly captures the old lingering weakness. New acute stroke plus old residual deficit equals code both.
Section 5. TIA versus completed stroke.
We really need to address one of the most common auditor traps in the entire industry by defining the strict boundary between these two. A transient ischemic attack, coded as G45.9, represents a temporary event. These are neurological symptoms that resolve completely without actual tissue death. On the other hand, a completed infarction coded in the I-63 category occurs when imaging confirms actual tissue death or necrosis. I want to strongly warn you against assigning unspecified CVA codes when the specific etiology and side documentation exist. You literally must read those imaging reports.
To really test this concept, let me pose a challenging scenario for you. What happens if a patient presents with clinical symptoms, maybe slurred speech or facial drooping, and those symptoms resolved rapidly within a few hours, but the MRI brain scan clearly shows a localized ischemic lesion indicating cell death? Think about it. Do you code the temporary symptoms or the MRI results?
So the crucial point is, the diagnostic label flips entirely. It absolutely cannot be coded as a TIA, even if the outward clinical symptoms resolved super rapidly. Because the imaging confirmed tissue death, you must code it as an acute cerebral infarction from the I-63 category. Imaging evidence of an infarction always overrides the temporary nature of the clinical symptoms. Do not let rapidly resolving symptoms trick you into using a G45.9 TIA code when the MRI proves otherwise.
Section 6. Escaping Chapter 9 Traps.
Let's go through some rapid-fire CMS default rules to ensure your accuracy is absolute, especially when physician documentation is less than perfect, which, let's be honest, happens a lot. When coding hemiplegia, hemiparesis, or monoplegia, like codes from categories G81 and G83, you have to know if the affected side is dominant or non-dominant. But what if the record is completely silent on dominance? The rules step in here. For an ambidextrous patient, the default is dominant. If the left side is affected and dominance isn't specified, the default is non-dominant. If the right side is affected, the default is dominant. Memorize these 3 defaults right now. They will save you time, they'll prevent coding delays, and they will keep you completely safe during audits.
As we wrap up this explainer, I really want to leave you with this thought. Are you coding based on the true clinical timeline and residual deficits, or are you just guessing? Your responsibility as a coder is to paint the most accurate clinical picture possible, proving exactly why a patient needs a certain level of care. And you do that by mastering these official guidelines. Thank you so much for joining me for part 48 of the series. Be sure to subscribe, hit that like button, and share this explainer with your fellow coders to keep the education going. Next time, in part 49, we're moving into Chapter 10, Diseases of the Respiratory System, where we will conquer section IC10A on chronic obstructive pulmonary disease and asthma acute exacerbations. It's going to be a great one. See you then.